talked about some of that pro planning, and you said you try to line up a lot of that with the local planning, and I think we dive down this rabbit hole now because this is something that's actionable for this audience, right? Is how does that vary, and what steps do we need to take at a local level when we're interfacing, when we're covering these events, or when they're in our jurisdiction?
Yeah, right. And I think that's a lot what it comes down to is what's your jurisdiction, what are your rules?
Sure.
What do you have to do? And then it's having that communication with the athletic trainer. I've had a lot of discussions with athletic trainers that maybe don't understand the liabilities that come as soon as you guys step out on the field. It is now your patient, your liability.
Yeah.
So regardless of what the athletic trainer wants to do, it's going to be what you're supposed to do based off of your protocols, right? And so it's having those conversations beforehand, and that's something that I've worked very closely with Jeff Luke on over the last couple of years to make sure that they've done a really good job. But when I got here, it was transport athletic. We want to transport everybody as quickly as possible that has hyperthermia, and we've gotten that. Now, Jeff has done a fantastic job of getting it into the protocols where there's a disclaimer basically at the bottom that says if they're in a cold tub, leave them there, get the rectal temperature, and do all of those things, and then transport them once they're stable. And that's really the only time, but it's a very crucial time, and we've seen that in Northeast Ohio. We had a player at Kent State a couple of years ago that he had to be transported because there was that wasn't in place, but we saw what his temperature was whenever he got to the emergency room after having ice packs in the groin and the axilla and cold IVs going through, and his temperature was still very, very high whenever he got to the emergency room.
Yeah, we're talking about it now. Let's just continue focus on that EMS care of the hyperthermic patient, right? Sure. And those changes that we instituted in 23. So those are all for this year. And again, the crux of that, you touched on that, was whenever, and at these sporting events, part of that planning, of course, is having availability of a tub and ice and water.
Because remember when that came out, you and I had a phone conversation. How can we make this work?
How
what
can we
use?
This? Yeah.
And we started talking about even using maybe thick body bags at one point, making walking tacos. And the trickle down effect is so funny that it just to reach it on our level even, it's big stuff though.
Well, for so long, those were load and go things, right?
We didn't do anything else.
And it was projected upon us that turning the air conditioning on in the truck and making them naked and spritzing them with whatever we had in the truck was going to be sufficient to dive core temps. And
boy, was it different though when the protocol came out and said now we're going to stay on scene, and people got really scared. So it took a lot of education.
A ton. A ton.
It's a huge culture shift, just a different change.
Yeah, absolutely. And I think there's not a good thing about any of this, but the thing that makes this work is that you have a half an hour. That first half an hour is so crucial to getting the temperature down.
Outcomes.
If you can get that temperature down within the first half hour, your likelihood of having a good outcome is 100%. There's very few things in medicine that you can say it's 100% of the time. And so you get questions about, what happens if somebody has a heart attack? Well, the Corey Stringer Institute has looked at this. Over 3,000 cases of hyperthermia in an athlete. There was one person that had a heart attack. They were monitoring him. Started to struggle in the tub. They pulled him out, shocked him, got him back, put him back in the tub. Left him in the tub until his temperature was less than.
That's how important it is.
That's how important it is. Yeah. And so, you can do things like that. Now, you got to know, and you got to have that rectal thermometer and that core temperature so that you know what's going on with the temperature, and then you can transport them once you get down below basically 102. And so, above 102 without, again, getting too far into the weeds, the body can't regulate the temperature. And so we know from all the studies that have been done that that an ice bath that is being stirred will lower the body's temperature by about a half a degree a minute, and we saw that at the marathon we were talking, or the triathlon. It was triathlon a couple of years ago, where we had a guy that had a temperature of 108, basically.
That's nuts, yeah.
And we put him in the cold tub. He was in there for 20 minutes. When we pulled him out, it was 98 degrees.
That's awesome.
It was amazing.
Right.
And he walked out of the hospital that day. Like, he went, got he checked out, walked out of the emergency room, discharged that day. Really not a whole lot worse for the wear. Where if we take them and send them first, depending on how long it takes to get to the ER,
Correct.
and most ERs don't have the capabilities to be able to take care of an athlete that has a temperature that high.
Yeah. Anybody, not just an athlete,
not
right?
just an athlete, but anybody.
We're not singling out the.
No. And I think, kind of getting to your point about what to use, it's not overly expensive. There's just a couple of things that you have to figure out what you're going to do. And number one is having a vessel big enough to hold a human being.
Yep.
And you can go and get, Jordan McNair, I believe the Jordan McNair Foundation, or he was a football player from the University of Maryland. Yeah. Ended up passing away from heat stroke, and his foundation that was created in his memory will get you a cold tub.
Oh.
They're only about $130 if you apply for it. They have a grant to be able to get it, and they will get it out. We've had a couple of schools that have used them. It really doesn't matter what it is, but it has to be in the shade. And the hard part is a lot of times getting the ice. Not every school has an ice maker. Not every school has. So if you're going to have those, and it's that planning at the beginning of the year, so that you can go out and either talk to the boosters and say, hey, we've got a practice coming up. We need ice. We don't want it in the tub because we don't want to melt the ice, but we need some place to store it where we can have the tub filled. So we got to be in the shade. We got to have access to water. We got to have access to ice. And those, hopefully you never have to use it. But those are the things that you've got to think about beforehand.
Yeah, cool thing about ice is if you keep it cold, it's not perishable.
Right,
you can keep it for a while.
You can use it forever.
Tell that to the icebergs.
And down a global warming rabbit hole we go. But to your point, when we put that training out, there was a fair amount of pushback. I know I certainly answered a bunch of questions. I'm sure you guys did too. Was
depleting resources, time on scene,
and again that stat about that first 30 minutes I think is super important as a take-home point. They really needs to stick in their head is what you do is important, right? Mm-hmm. So if that means send somebody across, grab a tarp off the engine, hose from the house, assuming it's not at a sporting event, right? What if you just come across, hyperthermia and, regular care situation, right? Sending somebody across the Quickie Mart to buy, the $4 worth of ice, right? And tarping them in the backyard before you go. It's worth the time to do that, right? To save brain cells and save organs. That's a hard pill for a lot of people to swallow.
It is, and we still, we were doing an emergency action plan earlier this year with a group, and came across the same question. This is the scenario. What are we doing? We're going to take them. We're going to take them and go.
Yeah, it's a hard mindset to get out of.
It's that, it's not in the collective consciousness yet that this is what you have to do for these athletes. And 3,000 cases, it's not like this was a small study that they did or a small amount of cohorts that they looked at. This was 3,000 cases, and they looked, the 4 outcomes were death, survival with permanent disability, survival with short-term disability, or survival with no disability. Those were the 4 outcomes. Anyone that was cooled to below 102 within the first 30 minutes had either survived. First 2 was either survival without disability or survival with short-term disability that resolved. So, it really is impressive, and like I said, in medicine, emergency medicine, primary care, whatever it is, there are very few things that you can say if you treat this way, they will survive 100% of the time with little to no disability, and if you don't, it can mean death. That's a very stark contrast.
It's very, very, and then so that, and then the other portion of that, which is if they start seizing, if they start vomiting, if they have diarrhea in the tub, still the best thing for them is to stay in it, right? And that again seems counterintuitive, for specifically for EMS, right? Whereas we want
treating them there, and it's a mindset change, and I think the shift is starting though to really get the transition from we have to take them, we have to transport them now, where it's just that's not we know
dive them now.
We have to dive them now. We don't need to transport now. It's not going to be beneficial for that patient at all. Actually, it's going to increase our mortality rate. So why would we transport? And you change the mindset. And I think a lot of times now we give them the why. We give them all of the study examples. I know as part of your FRST class that I'm sure we'll get to when we talk about it's in there. All the data on how to cool an athlete. This is if you put them in a cold shower. This is how long it would take to decrease their body temperature versus doing the ice bath. And I think that really shows EMS the importance of this, the importance of having a plan and what's going to be the most beneficial, because it could be at somebody's house. Right now it's extremely hot out. Think outside the box. They have a bathtub. You could fill it with water and
send somebody across the street, or
we can go buy ice. It's very cheap to remedy this. But at the hospital, at the receiving facility, and I know Dr. Hill and I have talked about that. There are no capabilities. We don't have the bathtub to fill up. We don't have we have ice makers. Sure, we have that resource, but what are you going to put them in?
So body bag. That's about it.
Yeah, like a makeshift thing that's not going to be as effective as just treating them on scene. So
and I think that's where some of the pre-discussions at the beginning of the season when you're talking, because you're talking about inserting a rectal thermometer into a younger than 18-year-old athlete, and unfortunately in this day and age, taboo, you're going to get some pushback. But it really is. It's you have to have that in order. There are some things that you can kind of substitute. It's not perfect. Once they start shivering, they're below 102. Once, if they have any mental status changes, once they come back from that mental status change and they become more reasonable, or their cognition comes back, that's when you can transport them. Now, we want to get them to the hospital as quickly as possible. So once they hit that 102 and it's safe to transport them, because you don't want to waste those resources, and you don't want to have that time on scene that's too much. So you can talk to that athletic trainer and say, hey, look, we really need, we need your school to be able to sign off on an emergency action plan that says a rectal thermometer is going to be used. And that can be difficult. That can be difficult to do. And if not, then you want to know the time in the tub. So that's talking to that athletic trainer and saying, hey, look, I need you to document. I need you to be able to at least have somebody write down when they go in the tub, because if they're in the tub and it's cold and it's being stirred, it's going to take about 20 minutes to get their temperature down. Sure. And so you want to have that number. You don't want them to go, it was probably, I don't know, we called you and it was 350 and we got them in the tub maybe 5 minutes before that. The time goes either so slow or so fast. Correct. In those situations that your recollection of it just isn't right. And so making sure that you can do those things and have those discussions beforehand.
So let's say they are altered, right? As many of these cases are. We put them in the tub. What are some strategies to make sure that they don't?
Right. Yeah. And so we actually
they don't become a diving accident.
Exactly. Yeah. No. We did this a couple of years ago at our athletic training kickoff, and I wasn't going to make somebody. We just felt I was so thankful they didn't put any ice in there, because I was going to be the downed athlete. So they filled it up with water. It was still cold, and that immediate, once you hit it, your first thought, you take that big breath in. Right? Yeah, exactly. And so when we did it, I purposely, I said, I just want you to pick me up and put me in. And so they picked me up and put me in. The first thing you do is slide underneath the water. And so when you're having those athletes, it depends on what you have. There are some people movers that they use that are big tarps that have straps, and you can pick them up and put them in the water. Those are great to use, because that not only will allow you to be able to get the athlete in, it will allow you to be able to get the athlete out of the water.
It adds handles to humans.
Exactly. It's got handles. It makes it super easy. But at a bare minimum, you want a towel or a shirt or something underneath the armpits that you're holding onto behind them, so that whenever you put them in the water, you have control over that person.
You got to commit somebody to holding them above water.
Hold them above water.
I think a benzo might help too if they start to become combative or such.
Yeah, absolutely. You know, you don't want them thrashing around in there, because the more they thrash, the more their muscles are going to make heat, and the more the body is already unable to control it. So you want them calm. You want them moving as little as possible, and the only thing, you know, is just keeping that water being stirred.
So don't set it and forget it. Walk away.
No, you got to keep an eye on them.
Yeah, no, this is full time and attention, bro.
It's not like soaking the turkey for Thanksgiving.
You know, and even with that method, you know, with just the head out, you can still do a fair amount of monitoring. You know, so certainly capnography.
I think we had a blood pressure cuff on ours, and I think we had a pulse ox at some point. Capnography.
You do a pulse ox on an ear or something if you needed to.
Yeah,
but
I still think we ended up getting 2 IVs. It was a lot happened all at once, but with enough people around. This was the case. He was talking about the triathlon. I remember this one. It was the first one I had ever experienced, and it was just really different.
Yeah.
It was like,
yep. Yeah. No, it was wild. And I remember him, you know, even though he was a little bit altered, he did not want to get in the pool.
Right, and then it's almost
through this before.
To you, like patient advocacy, you're like, I'll let the poor guy out, and then it was like, no.
Yeah, so just to kind of go through the whole scenario, he comes into the tent, he's a little bit altered, you can tell he's just not quite right. We took a temporal reading on him. It was 105.1. We said, all right, we're going to take him.
And we know those are
him.
spot on.
Well, and so that was the interesting thing. You know, we got him in the back. We got the rectal thermometer on him, and his temperature was 108.3. So you're a difference of 3 degrees.
3 degrees,
right? And that makes a big difference, because that 3 degrees is another 6 minutes in the tub.
Yep.
Right, and so if you pull them out too soon, and the likelihood of them going back up is probably slim at that point, but it still can happen in the rig. And then you've got a 10-20 minute, and then you're getting them somewhere where now they're spiking back up, and they don't have the ability to cool them down. So that 3 degrees makes a difference. That having that rectal thermometer, and I think that really illustrates how important that rectal thermometer is.
Now, is that something that you would advocate the department's purchase, or is that something you would expect the athletic trainers and whatnot to have?
The athletic trainer should really have them.
Yeah.
You know, that's something that the school should have, and the hope is you never get to that point, but you want to know, that heat illness is a spectrum where you can start, normal and go all the way to heat stroke. But somewhere in the middle is when hopefully we're recognizing those athletes and saying, all right, we got to get you out of the sun. We got to get you cooled off. We got to get you in the tub. And you want to know what the rectal temperature is, because some people can be completely lucid and they'll go like that, where it's pretty quick. They did a great timeline. They did a timeline for Jordan McNair. And it was interesting to kind of see the different things that happened during that timeline, and you could pinpoint that spot where he went from heat illness, kind of a just not run of the mill, but a heat illness into heat stroke.
Prototypical.
Yeah, it was he was okay, and then he just kind of fell off and went into heat stroke. So you can, you want to get these kids beforehand, but you need to know what that is.
Yeah. And part of that planning, of course, is to make sure that whomever you may be in your response, and I think you talked to this a little bit earlier, off camera, is that, that pre-planning with athletic trainers and whatnot, make sure that they have it, and all the simple stuff like it works and batteries are in it and stuff like that. But then, brief your crews on,
this is what we're going to do.
This is what we're going to do, and it's going to stay, and they're going to come with, and all of these things are okay for the betterment of the patient. So
actually, and so in our organization, we after taking the FRST class and then becoming an instructor for it, we facilitated a meeting with the athletic team at our school, the athletic trainer, coaches, and I know we use football a lot just because 2-a-days, it's hot, but it could be other sports. But it was kind of around that time, and we started our first meeting, and then we actually worked everything out. We had our incident action plan. This is what we're going to do. This is how we'd cool an athlete. This is where we're going to take them. Looked at all the equipment the athletic trainer had, and then we actually had each one of our shifts go. So they were really open, and not everyone was at the table at the second one. We essentially narrowed it down to work with the athletic trainer. So, but still, we had all already agreed, and then she's been excellent with us. And I think it's just beneficial for every crew member to go there and see, hey, this is visually going to be the plan. This is what we're going to do. This is how we're going to communicate. We're all on the same page. Especially because when that emergency occurs, specific to heat illness, time is of the essence to get that patient in the ice bath and benefit them. And you're going to have a better outcome for the athlete too.
Yeah.
And we always talk about too, prior planning is so important versus, Friday night lights when those stands are full. We all want to be on the same page, no matter what that emergency is, whether it's heat illness or commotion cordis, it doesn't matter. We all want to be on the same page and help the athlete. But that helps with us. It bridged our gap.
We are.
And it was just something to I don't want to say it was an oversight, but it was one of those, well, it really hasn't happened here. We haven't had a major incident. So, do we really need to do that? And after, taking that class, I think it opened everybody's eyes to it. And it's been great. Everybody's on a first name basis with the trainer. It's
awesome.
It works out really, really well.
And the fact that you got everybody there, all the shifts, because it's not just going to be the same shift, right? Everybody thinks again Friday night lights, so it's that that shift that's on 7 o'clock. Well, more than likely it's going to be a practice that's going to be early in the day, or it could be late afternoon, and so you really have to have everybody on the same page, and having a first name basis and doing all those things is awesome. I mean, that's why we put the course together, is to open that line of communication and the dialogue between EMS, because there has to be a mesh point, right? Yes. There has to be a time where you're going to hand off control of that patient from the athletic trainer to the EMS. And I mean, there are just stories upon stories of how that doesn't go well. And you don't hear about the ones that do, but that's awesome.